Right. So let us try to understand the MRI of the avascular necrosis. You can actually see here that this one is a T1 image, okay, T1 coronal view, okay, and of the pelvic bone we have taken out, and then we can actually trying to visualize both of the femoral heads, and you can actually see that on the right femoral head you can actually see that there is a normal density, normal signal intensity. But when you actually compare it to the left side, that there is a hypo intense signal on the femoral head of the same patient, right? The same patient, what we looked on the conventional radiograph, here we can actually see that there is a decreased signal intensity, or we can also call it as hypo intense signal on the femoral head, is actually a classical feature of avascular necrosis. Okay, so that is how it is, right? And you can also see here one thing, that in avascular necrosis there won't be any joint related problems. So generally speaking, the joint space is preserved. So you have to understand this is not a problem of a joint. This is not a problem of a joint, but this is obviously a problem of a articular surface. Okay, when actually you are talking about the joints, you actually need to look at the both articular surfaces, which means to say the proximal part of the bone that is actually forming the joint is actually the one that is connection formed between the two bones, right? Two different bones. Let us say here, for example, it is actually forming down between the acetabulum and the femoral head. So you, at the same point of time, you have to also look at the orientation or the contour of the acetabulum as well. So when you look at the acetabulum, what actually it has to look like, if it has to be related down to a joint problem, that the acetabulum and the femoral head, the space between them should be compromised, which is actually suggesting you a diagnosis of spondylitis. But this is not spondylitis, because I can particularly say that the acetabulum contour is completely normal, and there is only signal intensity changes that are present down within the femoral head itself. Okay, so that's the reason I came to understand that this is avascular necrosis, but this is not spondylitis. All right. So we will talk about the spondylitis in joint bone disorders. Okay, ankylosing spondylitis is a condition which we will be seeing that whatever the joint spaces, if they are compromised or not. Arthritis, osteoarthritis, yes, there are so many joint diseases, but we will learn that concept there again in joint diseases. But right now you have to understand here, this is not related anything that has to do with the joint, but it is only related down to the articular surface, which is the femoral head, and it is actually happening because of the avascularity, right? So that's it. And remember, MRI is the confirmatory, the most sensitive, and the gold standard diagnosis, in a gold standard investigation for the diagnosis of avascular necrosis. So that's the message here, right? So then we are going to get down to the Paget's disease. Paget's disease is a chronic disease of the bone, which actually occurs in the older men. Okay, and however, it is also believed to be caused by the chronic paramyxovirus infection. Okay, Paget's disease is an infection. Technically, it is believed to be caused by the paramyxovirus, right? And then it is characterized by varying degrees of increased bone resorption and increased bone formation. So, which means to say there is an overactivation of the osteoclast, and there is an overactivation of the osteoblasts as well. So, that is actually called as the Paget's disease. However, here in this particular situation, the osteoblast one, the new bone formation, increased bone formation is done by the osteoblastic activity. So the osteoblastic activity is much more predominating, so which means to say there will be increased densities in all those areas. So that is what we are talking about, the Paget's disease. All right. So it is a chronic infection of the bone, Okay, it is characterized by the increased activity of the osteoclasts and the osteoblasts. Or on the other way, you can actually say it by the increased bone resorption and increased bone formation, right? So that is how Paget's disease is. And we can always see, because there is always increased in the uh, osteoblastic uh, cells. So what actually happens, there is an increased density of the bone, so denser bone appearance, and then there is a mechanically inferior to the normal bone. You see here, every bone that is formed may not be really a healthy tissue itself. So it is mechanically inferior. Mechanically inferior, it means to say that it is not able to sustain the stress or the tension that is taken down by all the bones. Okay, bone, the main part of a bone, the main function is actually it has to give support, it has to aid in the movement, it has to actually bear the stress that is taken down by these activities. But in Paget's disease, yes, that the bones are there. There is it is a new bone formation, but still it will not be mechanically able to sustain the stress that is taken by these parts of the bone, which usually they have to take, right? So that's the main pathological feature of the Paget's disease. And that is the reason why, since it is mechanically inferior to the other parts of the bone, so that's the reason there will be susceptible pathological fractures, right? Which will eventually lead down to a condition called as the bone softening, which is called as the bowing. Okay, bowing of the bones is happening, are a characteristic feature of the Paget's disease. Okay, and here pelvis is the one that is most frequently involved, which is followed by the lumbar, thoracic, and the proximal fever, along with the calvarium. However, in a clinical setup, generally, even though pelvis is frequently involved, what we actually try to diagnose a Paget's disease is from the calvarium. Okay, calvarium means to say we are talking about the skull. Okay, the confirmatory diagnosis of the uh, Paget's disease is actually made by the skull, which we will be actually seeing up the skip lesions on the skull. Okay, there are two types of lesions. Two diseases particularly actually causes the skip lesions inside the skull. One is multiple myeloma. Okay, skip lesions we call them as skip lesions. Okay, multiple myeloma. Okay, skip lesions, multiple myeloma, and Paget's disease are the ones that actually causes such kind of appearance. Uh, So here you can see that there are only particularly very few radiographic features of the Paget's disease, but still they are widely confirmatory. So what are the radiographic features? They are the thickening of the cortex. Well, obviously understand that there is an increased osteoblastic activity, so increased thickening of the cortex, increased bone resorption, yes, again thickening of the cortex, right? And then attenuation means to say loss of density, attenuation of the trabecular pattern. So since the bone resorption is going to happen, yes, it has to be taken down from the medullary cavity and the trabecula as well, right? So there will be decreased density of the trabecular pattern and thickening of the cortex. So understand one thing here: when you are trying to learn it, when you're trying to diagnose a disease of osteosclerosis, okay, increased bone density, there will be thickening of the cortex, but will be attenuation of the normal trabecular pattern. Remember this as a final thing. Okay, whenever the final whole take home message of the hyperosteosclerotic diseases is that there will be thickening of the cortex and there will be loss of density of the normal trabecular pattern. Simple. That's it. Okay, all the bone increased bone density diseases, yes, this is the take home message. And you see here in this radiograph that the particular parts of the bones, okay, particularly along the ischial tuberosities, okay, and the femoral head, we will actually see that there is increase in the thickening of the cortex. You see here, but when compared to the opposite side, you see here the densities are particularly increased along the cortex of the pelvic bone, right? Ischial tuberosity, there is an increased, this is actually the pubic rami I'm looking at, okay? Inferior pubic rami and the superior pubic rami, right? These are the two parts. So inferior pubic rami has got the increased density of the cortex. So can we conveniently say that the femoral head will be normal here? Yes, obviously the femoral head is normal, but it is actually causing a heterogeneous density over the femoral head. So in such kind of a situation, you cannot act, there is a liability that you can make a misdiagnosis, this one as the particularly saying as the avascular necrosis, but it is, you look at the joint space first thing, and then you look at the contour of the femoral head, which appears to be completely normal. So this shadow is actually caused by the obscuration of the cortical thickening of the pelvic rami. So that's the reason we are telling this as Paget's disease, but not as an avascular necrosis. Were you able to understand the differential diagnosis here? How we were able to differentiate if it is the avascular necrosis or if it's a Paget's disease? Yes, is this concept clear? Right? Yes? Okay. Now, you also have to understand one thing here. When I have been talking about the trabeculae, there is also increased osteoblastic activity, right? If there is increased osteoblastic activity, which means to say the trabeculae will be becoming more thickened as well. So, such kind of a concept is actually called as the coarsening of the trabeculae, right? So, two radiographic features: thickening of the cortex, attenuation of the trabecular pattern, and coarsening. So, this is the final feature of hyperosteosclerotic bone diseases. Simple thing. It can also happen because of the normal looking trabeculae. It can also happen because of the increased osteoblastic activity causing the coarsening of the trabeculae. The exactly opposite thing is actually happening in decreased bone density. So that concept is completely very simple right now. Okay, right? Exactly. No effect on joint space in avascular necrosis. Even in Paget's disease, also there will be no joint compromise, but still it appears to be that the joints are completely closer together, but symptomatic wise the patient is not going to complain of any stiffness, but he is going to complain only pain, right? Which is related down to the osteoarthritis, rheumatoid arthritis. The patient has to complain the joint stiffness and joint angulations and deformity should be present. Okay, depending upon the joint stiffness, yes, there will be a lot of pain, but in Paget's disease the patient is only going to complain a pain, but there is no joint stiffness. So that is how we can also differentiate them clinically, right? Okay, you can also understand one thing here: computed tomography. On the computed tomography we can actually see that there is you see here there is a thickening of the uh, cortex of the right, there is a thickening of the cortex of the right, the pubic rami cortex when compared to the left one. You see here, this is the normal trabecular pattern, and this is the normal cortex that is present on the left side. But you compare it onto the right side, there is the thickening of the cortex, and there is increased density and coarsened trabeculae. So that is the Paget's disease. That's how we were able to make out the diagnosis of the Paget's disease. But when it is compared down to the spondylolysis, okay, which is actually the joint inflammation, okay, spondyles, where is the joint inflammation, that one will look entirely different. Okay, so we will try to learn that in joint diseases as well. Well, Dravendra, you have been asking, okay, can it be cured by normally by physiotherapy? Well, you see here, you understand that this is not a problem that is related down to the anything that is related down to the joint activity. Physiotherapy is actually including the exercises that is related down to the joints. It has got nothing to do with the bone metabolism, right? So do you think that physiotherapy is going to help a person with Paget's disease? Yes, fairly a very little, I guess. Yes or no? Or are you talking about the avascular necrosis problems? Or are you talking about the joint related problems? Which one are you particularly talking about if you are talking for physiotherapy? Well, about pain, see, not every pain is related down to a joint. Not every pain is related down to uh, uh, pain can be attributed down to the posture and physical activity. But generally speaking, in Paget's disease and in avascular necrosis, you see here in Paget's disease, generally the increased activity of the osteoblasts and the osteoclasts should be controlled by the medicine like methotrexate and cisplatin. But in avascular necrosis, you cannot actually recommend the patient to go for an exercise. Yes, there will be pain, but you cannot recommend the patient to go down to do the exercise. Uh, the good way of controlling an avascular necrosis is actually immobilization and the patient having a rest for at least 3 months. All right. So it is actually you have to increase the blood supply, and a continuous heat and cold therapy is going to increase the blood supply to the femoral head. So the patient is also taking rest in bed. But it when compared down to the rheumatoid arthritis and ankylosing spondylitis, yes, activity is the one that is actually being recommended to the patients. You understand? See, pain is directly related down to the physical activity and the stress on the bones. But here it is the metabolic bone disorder and it is going to be controlled by the drugs. Okay. In case of rheumatoid arthritis, we are going to control it by DMRADs, okay, disease modifying rheumatoid arthritis drugs or anti-inflammatories, okay, something like NSAIDs, right? But avascular necrosis, yes, the pain will be controlled by the NSAIDs, but actually immobilization and non-exercising is actually that is one recommended for these people. All right. Okay. Now we are going to look at some of the diseases that is related down to the decreased bone density. We will be talking about as two particular diseases as the focal and the diffuse in decrease in the bone density. Okay, right now this part of the chapter is fairly very easy to understand. We have got our concepts very strong now. Now you see here in decreased bone density, you see here there is a diffuse loss of the normal trabecular network. Fair enough, it is quite easily understood right now. You see, there is a loss of normal trabecular network, okay? And there will be thinning of the cortex, and all the trabecular structures become smaller. So, now, don't you think that, let us say, all the parts of these bones, okay? Let us come back to our same first image, what talking about here before, right? Okay, so what is actually happening? You see here, look at the same trabecular image here. The thing is that you see here, this trabeculae become thinned. Okay, this trabeculae become thinned. So as they started to become thinning, don't you think that the spaces in the lacunae increases? Yes or no? Right? Understand the concept carefully. Now this trabeculae has become thin, and which means to say there is an increased space in the lacunae. So how will that trabeculae look like? their trabeculae will look whiter, but still looking thin. Did you understand this concept now? Apply the same kind of shadows what we have learned from the checkerboard illusions, right? There is thinning of the trabeculae, but they will become more prominently seen. Yes or no? Yes, guys, reply me. Right? Thin and white. But actually, it is not thinning. It is the thinning that is actually causing them to be more white. But do you think that they are really white? No, obviously they are not really white. But because they have been placed under the you see increased lacunar shadows, which is black, so that's the reason they are appearing more white. Did you get this point clear? So that's it. That is what the thinning of the cortex, which is actually happening again in the osteoporosis. So thinning, diffuse loss of normal bony trabecular network in the medullary cavity, thinning of the cortex and many trabecular structures is the main characteristic feature of a decreased bone density. And you see here, again, the same thing is going to happen. There will be attenuation of the normal corticomedullary junction will be seen, right? So since there is a decreased activity of the osteoblasts there and increased activity of the osteoclasts there, so that is what happening. There will be loss of density or the attenuation along the normal corticomedullary junction. So that is the second radiographic feature. And you see here the other more things actually happens is that yes, they stand out more strikingly. So that's the reason, because there is a decreased density of the medullary cavity. That's the reason they become more prominent, they become more striking, they become more white. But actually they did not really become white due to calcium deposition, but they actually became more white and prominent because of the black background, right? So that is actually called as attenuation. Loss of density when compared to the surrounding structures is actually called as attenuation, right? Okay. At the same point of time, you have to understand that the trabeculae become thinner, right? The trabeculae become thinner. Just a second. Give me a second, please. Hold. I'm sorry, I had to take a phone call. All right. You see here, when the trabeculae has been thinned right now, which actually lost its capacity to bear the stress. So, what actually happens is that they are eventually going to lead the compression and they are going to break, particularly where there is a lot of medullary cavity. And in all those tissues, what actually happens is that it will be causing the compression fractures. Okay, particularly remember in case of osteoporosis, wedge compression fractures. Okay, wedge compression fractures are the characteristic feature of osteoporosis. Okay, it's quite simple. Wedge compression fractures, because there is a thinning of the trabeculae, they can no longer bear the stress, and so they will be eventually compressed, and that will actually cause the vertebral fractures. Okay, and now again you have to see in osteoporosis like condition, pathological fractures are always present, and they will be happening mostly in the hip, pelvis, and the vertebral bodies. Okay, so pathological fractures are common in decreased bone density diseases, right? So the first disease that we are going to learn is the osteoporosis. Osteoporosis is a metabolic bone disorder, okay, which is the systemic skeletal disorder characterized by the low bone mineral density, which is actually called as the BMD. Okay, low bone mineral density, and it is actually happening because of the endocrine activity that is related down to the estrogen. Estrogen is also one of the hormone that actually controls the calcium metabolism deposits. Okay, and that one is actually the increased activity of the estrogen that is happening after the menopause is the one that is actually related down to causing the low bone mineral density. So it is most commonly seen in postmenopausal women and also age related bone loss condition, right? Okay, well, it is actually characterized by increased bone resorption, which means to say there is an increased osteoclastic activity, right? Increased osteoclastic activity causes increased bone resorption, so which means to say there is loss of trabecula, right? So age related bone loss generally starts around the ages of 45 and 55, and it is slowly and slowly they are going to cause the total bone mass. Right now, you have to understand a little small concept here. Whenever the body, uh, let us say, whenever the bone has got decreased calcium, okay, there is an increased bone resorption. So, what is the signal that is sent down to the body? Yes, it is actually happening because of the estrogen, which means to say, still the thyroid, parathyroid, and the adrenal glands are completely normal. So, which means to say, they will get a triggering reaction and they will try to activate the calcium absorption more and try to get it more back into the bones. Yes or no? Yes, listen carefully what I have been talking about. First, there is loss of calcium inside the bones. So, because of the estrogen activity. So, then what actually happens is that the parathyroid hormone and the thyroid, adrenals, and pituitary are completely working normal. So, which means to say they will send a signal to the body saying that yes, calcium deposition has to be taken place. So maybe at some point of time there will be increased calcium levels inside the, okay, inside the blood. But right now what actually happens is that all the calcium that has been absorbed is going and redirected towards the bones. But still inside the bones it will be increased bone resorption, increased osteoclastic activity. So which means to say whatever the calcium that has been deposited is again being degraded. So overall, what happens over a period of time at the subacute cases or the acutely forming osteoporosis conditions, maybe yes, the patients will be seeing as hypercalcemia in serum, but decreased bone mineral density inside the bones. But after few years, what actually happens is that there will be complete loss of serum calcium and also complete decrease of the bone mineral density. Did you understand? Because whatever that has been depositing, it has been continuously being metabolized and it is completely being resorpted. So, which means to say there is no calcium that is left from the body to reuptake again. That is called as osteoporosis. Is this concept clear? Did you understand? Why? S- It is bone mineral density seems to be much more sensitive when compared down to the serum calcium levels. So, if Ankita, if you have got low serum calcium levels when you have gone down to the doctor before, it will not be happening because of osteoporosis. Because when the menstrual cycles are completely present, estrogen activity is suppressed and the progesterone activity is high, you will not be actually looking at the osteoporosis in case of young adults, but it might be happening because of something that is has to do with thyroid and parathyroid problems, but it has got nothing to do with your bones. Did you understand? Last time, Ankita, you were saying that, right? See, so that is entirely different story. You have to understand the concept here that yes, in acute cases, yes, there may be increased hypercalcemia, serum calcium levels are increased. But over years, again, the decreased calcium levels in the serum and also decreased bone mineral density, both of them are going to confirm the osteoporosis condition, right? But any time decreased calcium levels inside the blood actually indicates that might be related down to electrolytes, but not actually the bone related problems, right? In young patients, because calcium is also necessary for muscle contractions as well, also necessary for neuronal conduction as well. So that's the reason decreased calcium levels in your serum may indicate that it might be related down to endocrine problems such as thyroid, parathyroid, or generally a simple electrolyte imbalance, right? So your condition is not, I guess, is not related down to anything that has to do with the bones. Yes? So, if the doctor, if he did not ask about the joint disease history, or if he has not asked about your other systemic symptoms, I guess he has made up a wrong diagnosis there. So, I think you have to reevaluate yourself and go down to a particular diagnosis. See, that's what you got it there. But it doesn't necessarily mean to say that your bone mineral density is lost, right? That's what I have been talking about here. Exactly, osteoporosis, right? Okay. So I think maybe your doubt has been cleared what you asked something like few days ago. In the last week session, you have asked me why then I have low calcium serum levels, but why you still not having any kind of thing that is related down to the bones, right? So osteoporosis is fairly a a old age related problem, which is actually yes, particularly in females. But you have to understand yes, uh, people who are having hypothyroidism, hypoparathyroidism are more likely to develop osteoporosis in the later stages of their life. Okay, so you are at a risk of developing osteoporosis in the later stages of life because when the estrogen activity is again coming over, yes, it is again compensated with the hypothyroidism. The complete HPA axis is going to get disrupted, and yes, you are developing osteoporosis in early time of life. Okay, maybe I mean to say immediately, maybe something around like 40 years, oh sorry, 45 years or so, immediately after the menopause has commenced. So that's the time, yes, you are more likely to develop osteoporosis. So what's the best remedy? the best remedy is to keep a good exercise and to have good levels of calcium inside your body so that your bones get more depositions to compensate it during the old age, right? So I think your doctor should have actually, advised you about this. Well, let's see it. Right. And you see here, there is an increased risk of osteoporosis. You see here, the same thing I have been talking about here. When there is Cushing's disease, when there is estrogen deficiency and inadequate physical activity and alcoholism, all of them are going to cause the increased risk of osteoporosis, right? And again, these predisposes the individuals to the pathological fractures, especially such as the femoral neck fractures, and also a distal fracture of the radius. Okay, fracture of the distal radius, which is, we learned yesterday, the Colles fracture or the femoral neck fractures we have been looking yesterday as well. So both of them are increased risk. Pathological fractures are most common in osteoporosis. What are the most common regions that are present? The most common regions are the femoral neck and the Colles fractures. Okay, so osteoporosis causes pathological fractures in femoral neck and the distal radius. Colles fracture is happening mostly in old females. So that is how you remember that. Okay, and some of the drugs like corticosteroids also cause increased bone resorption, osteoclastic activity, particularly like dexamethasone. So people are on who are on anti-cancer drugs, or people who are on corticosteroids, yes, they are also more likely to develop osteoporosis. On conventional radiograph, you see here, generally we will be only seeing very, very fairly, let us say, if it is actually dependent upon the metabolism, okay, endocrine activity. So what actually happens is that they can be seen at different stages of bone resorption. Okay, so it is very difficult of diagnosing osteoporosis unless it is completely remarkably seen in very old individuals. Very old individuals, well, if you take an x-ray of them, yes, you can see the decreased bone density, but generally conventional radiographs are completely insensitive. So the gold standard test for recognizing osteoporosis is the BMD scan. Okay, bone mineral density scan, or you can also call it as a DEXA scan. Okay, DEXA scan you call it as. Okay, this is the gold standard test. BMD scan, which is called as the bone mineral density scan, or DEXA scan, is the gold standard for diagnosing osteoporosis. All right. Okay, and then you can see the radiographic features as the overall decreased density of the bone, as simple as that, and then thinning of the cortex, very well, because there is bone resorption, and decrease in the visible number of the trabeculae in the medullary cavity. And whatever the trabeculae that have been visualized are looking much more prominent. So prominent trabeculae, decrease in the number of trabeculae, thinning of the trabeculae, thinning of the cortex, and overall decreased bone density are the characteristic features of osteoporosis, right? And then we're going to look at the hyperparathyroidism. Okay, parath hormone is the one that is actually also causes the calcium metabolism related conditions, right? And parathyroid hormone exerts its effects on the bones, kidneys, and the gastrointestinal tract because it is directly related down to the calcium metabolism and calcium absorption, right? And it effects of the bones is to increase the bone resorption by stimulating osteoclastic activity. So calcium is removed from the bone and deposited in the bloodstream. You see here, right now, that's the same concept what I have been talking before. Calcium, whenever the body has less amounts of calcium, it will be taken down from the bones. Okay, and now when the bones has less calcium, what has to do? It has to be again activated from the bloodstream, and it is actually again coming down into the bone. So which one is the hormone that is doing it? It is the parathormone that is doing this condition, right? But in case of hyperparathyroidism, what actually happens is that there is an increased resorption, increased osteoclastic activity. So which means to say increased removal of calcium from the bone. Increased removal of calcium from the bone, which means to say it will be redirected down towards the bloodstream. So increased bloodstream, increased calcium inside the blood, hypercalciuria, hypercalcemia, and which will also cause increased calcium excretion. So hypercalciuria. So hyperparathyroidism will have systemic symptoms and decreased bone calcium density. Right? Did you understand this concept now? Yes? Is there any confusion? Right? Okay. So now, how the diagnosis is actually made? The diagnosis of hyperparathyroidism is generally based on clinical as well as the laboratory findings. Okay, and however, a numerous radiographic findings can also be seen. You have to understand that since it is an endocrine related condition, most of the times it is based on clinical and laboratory findings. Hypercalcemia, decreased bone mineral density, and which is actually related down to the muscle contractions, okay, will be seen in hyperparathyroidism. But on conventional radiographs, generally you see overall decrease in bone density, right? Something which looks like osteoporosis, subperiosteal bone resorption, since it is the osteoclastic activity. So that's what happens is in the medullary cavity, corticomedullary junction, you will be seeing subperiosteal bone resorption. Okay, and then erosion of the distal clavicles. Okay, erosion of the distal clavicles, right? And well circumscribed lytic lesions called as the brown tumors, which is also causing the salt and pepper appearance of the skull. See, salt and pepper appearance of the skull is generally called as a well circumscribed lesions. This is not skip lesions, this is called as lytic lesions. Remember, rather than understanding the concept, just remember one thing at this level: salt and pepper appearance of the skull is a characteristic feature of hyperparathyroidism. Simple. Okay, that's the take home message. Let's not try to get it really more and more difficult and more detailed. Okay, salt and pepper appearance of the skull is a characteristic feature and a diagnostic feature of hyperparathyroidism, right? Okay, and then what about decrease in the focal bone density? Okay, some areas of the bone are technically decreased. What else we saw before was the diffuse decrease in the bone density, which means to say all the bones in the body will be having decreased bone density, thinning of the trabeculae, thinning of the cortex, no matter where you are looking at. And particularly that kind of radiographic features are very very active in case of in case of uh, they are particularly active in case of like long bones. But in focal decrease of bone density is technically, you can see the slide. Somebody sharing the screen. Why is she between sharing the screen right now? Fine. Is it fine now? Yes. Right. Okay. So focal density is only certain parts of the bone is actually losing its density. So where there will be, focal infiltration of the bone cells other than osteocytes, it is actually called as focal loss of bone density. And which happens in osteolytic metastatic disease. You see here, this is the primary cancers of the bones. Okay, these osteolytic metastatic disease are the primary cancers of the bone, which will cause a focal destruction of the bone. But before, we saw that the prostate cancer, it is the secondary metastasis, right? So this is the primary cancer, primary neoplastic condition, but that one is the secondary neoplastic condition. Did you understand the difference here? Yes or no? Right? Yes or no? Perfect. Then you see here, right now, let's try to understand one simple concept here. The medullary cavity is almost always involved, and where the disease erosion is happening, and it will actually destroy the cortex. Okay, and but in some cases only the cortex is involved. You see here, an osteolytic metastatic disease will start to produce a focal destruction of the bone where the medullary cavity is involved, and it sometimes will destroy the cortex. Okay, so which one has to start at a focus at a single point, okay, where there is an overactivation of the osteolytic cells. That is the area it is actually starting to destroy that area, and slowly the other regions are being destroyed. So it actually, the extension of destruction is actually dependent directly on the amount of the osteolytic cells or the progression of the disease. So depending upon the extension of focal lytic lesions, we can actually determine the progression of an metastatic disease. So that's the take home concept here. What we try to do is that if we are trying to analyze the progression of the metastatic diseases, extension of the osteolytic lesions inside the bone will tell you what kind of a stage you are looking at. Okay, so let's try to find some classical radiographic features. The main characteristic radiographic features is actually the irregularly shaped lucent bone lesions, which are single or multiple. So multiple lucent l- lesions, okay, which I said like this called as the skip lesions. Okay, some areas are white, some areas are black. So such a thing is actually called as the skip lesions, is a characteristic feature of irregularly shaped lytic bone lesions. So multiple myeloma is a metastatic bone disease. So that's the reason multiple myeloma has got skip lesions. Did you understand right now? So let us try to let me find you a picture of multiple myeloma so that you can actually understand. See, which is also called as the salt and pepper appearance. Okay, and it can technically happen. Okay, it can technically happen in kids as well. Okay, uh, okay, look at the image I have sent you. Can you see the picture? And you see here, whenever you have got skull, remember, whenever you have got an image of a skull in an examination, without any question, you can directly choose the answer as multiple myeloma. Okay, but sometimes Paget's disease can also be also shown. Uh, Okay, you can say, I will show you the understand. You cannot actually confuse the Paget's disease with the what do you say, the multiple myeloma. Both of them are actually called as skip lesions, but there is a classical differentiation. You can actually call the Paget's disease condition as the hair on end appearance. Okay, hair on end appearance is a classical feature of Paget's disease, but they are also called as skip lesions itself. Okay, hair on end appearance. You can let me find a classical picture that is actually used always in the examinations. Just a second. Yeah. Or you can also call it as the cap sign. Okay. Also call it as cap sign or hat sign. Okay. Where this actually the x-ray appears, the x-ray itself appears that the skull has got its own hairs. Okay, that's the reason why we call it as the cap sign. Okay, or hair on end appearance. But you have to see, compare it to the multiple myeloma skip lesions. Multiple myeloma skip lesions are having the lytic lesions where there are hypodense areas and some areas are looking white, which is actually representing the normal areas. But here you see, here also is having some of the black areas, but that black areas are normal and all other white areas are looking as the hyperosteosclerotic condition, right? So both of them are trying to look appear the same way. So that's the reason they are actually called as skip lesions in both the conditions. But for diagnosis purposes, you actually call it as the skip lesions that are seen as lytic densities, which means to say hypodensities is a characteristic feature of multiple myeloma. But hair on and appearance with increased density lesions is actually a characteristic feature of Paget's disease. Did you understand? Yes or no? So do not try to confuse with both of these conditions, right? So sometimes in the options, if you do not see this, Paget's disease, you can choose multiple myeloma. Okay, or the other way around. If you cannot see Paget's disease, you can choose multiple myeloma. If multiple myeloma is not seen, you can see Paget's disease. Okay, but you have to remember one thing: salt and pepper sign is completely related down to the Paget's disease. Okay, or a hair on end appearance, but multiple myeloma is related down to the skip lesions, lytic lesions. All right, is this understood? Is there any confusion here? Okay. Right, because you see here in most of the Indian medical examinations, they are really, really very fond of asking the questions related down to the appearance. Okay, moth-eaten appearance, honeycombing appearance, hair on end appearance, water lily sign. Okay, so you have to remember these classical names. Okay, particularly when related down to the radiology examinations. Yeah, they are very, very fond of asking such kind of names, so they are quite confusing and most of the x-rays actually look normal, and the options are quite controversial and quite tight. So they say that the skip lesions are seen in, okay, right now you will be remembering them as multiple myeloma, but logically speaking, in the options you will be given Paget's disease. Yes, even Paget's disease has got skip lesions, but those skip lesions are actually hyperosteosclerotic uh, uh, skip lesions. Yes, of course, both of those diseases show different characters, but appearances wise, when you actually cause that, they will one that actually causes the confusion. Right, Benedict? Yes, obviously both of them show different characteristics. Both of them are actually showing black and white areas. That's the reason they are called as skip lesions, right? But one area, the lytic lesion, where the black area in the multiple myeloma patient is actually destroyed. But the black area in case of Paget's disease is actually the one that is normal. Yes, right? So, such kind of questions and confusing questions are quite famous in Indian examinations. So, unless we and until we understand the concept, yes, we are actually going wrong there. But okay, you guys are from Africa, but yes, what you have said is entirely correct. Yes, they have different characteristics. They have different appearances. But when we are trying to use the in terms of science and trying to remember a disease, that's what actually causes the confusion. I think Indian guys have understood what exactly I'm talking about. Yes? Have you seen questions like this before anywhere in some books? Dabelina, right? She's the one that has been doing a lot of questions from the competitive exam books. Have you seen any questions that is related down to this one, appearances? Or anybody reading any kind of, competitive exam questions? Can you tell me? Can you confirm me this? What about the Indian guys? Why don't you guys speak up? Is Debelina here in the class today? Interesting. Okay, fine. Sadaf, what do you mean by that? Right. Maybe when you are trying to do some competitive exam questions, remember you have to, completely by heart the sign names. Okay, so that's the reason I'm trying to be detailed in radiology classes itself, because this will certainly help you later on. Okay, and also remember that there is another one particular sign which is related down to the lytic lesions, which is actually called as the permeative pattern. Okay, there are so many types of appearances when it is down coming down to the osteolytic metastatic bone diseases. Okay, which is actually called as the permeative pattern, mottled pattern, or geographic appearances. Okay, so which is a characteristic feature of discrete bone lesions. Okay, permeative pattern, mottled appearance, okay, and geographic appearance is actually a characteristic feature of osteolytic metastatic disease. Okay, and they also have all these appearances. I have included them in the practical slides so that you will actually try to remember them. Okay, that is for your reading and understanding purposes later on. Okay, when I pass over the pathological slides, you will try to understand. Yeah, we will show the pictures. Just wait. I'll show you. Okay, right. So first, let's try to understand one thing here. Okay, we will start up with simple appearances. Okay, uh, there are more pictures are present down in the practical slides also. Okay, so that you can actually try to refer yourselves once again. But I will show the pictures here, but I won't describe them in detail. Okay, here you see here osteolytic metastasis. Generally, there will be little or no reactive bone formation around them. and they can actually become expansile. Okay, they will become bigger, and they will actually cause the soap bubble appearance. Remember, soap bubble appearance. Okay, soap bubble appearance is a characteristic feature, is characteristic feature of giant cell tumor. Okay, GCT, you call it as giant cell tumor. Okay, so how does it actually look like? You see here, there is a shaft of the humerus. We are looking at, obviously we are looking at the humerus, and what actually I can look here, that there is a very, very thinning of the cortex. Okay, there is a thinning of the cortex, and I can see that the whole trabecular density has been lost, but still I can see that there is a very, very thin covering of the periosteum around the area. So loss of trabecular density in between and with a thinned cortex area is actually called as the soap bubble appearance. So soap bubble appearance is actually happening in a giant cell tumor, which can also be happening because of the primary renal cell carcinoma, right? Renal cell carcinoma generally metastasizes down into the bones, and yes, it will also can happen if it is related down to the primary tumors of the bone. It is the giant cell tumor, okay? But if it is related down to the secondary metastasis, it can be happening because of primary renal cell carcinoma. So you can have to remember it like this. Soap bubble appearance may be found in, yes, primary renal cell carcinoma of the bones. Yes, metastasize it to the bones. Yes, that's correct. Giant cell tumor. Yes, it is also correct. Okay. So why Indian exams are so confusing is just because there are so many answers to the same question. So it is quite controversial, but still, yes, it can be accepted, right? So it is just about getting your concepts clear. All right, so this is the soap bubble appearance. Okay, and you see here thinning of the cortex is there, right? Okay, but there also, as well as the trabecular loss density. Okay, so that is the soap bubble appearance. It is just looking like a soap bubble, as simple as that. Okay, and then we can actually see that there is another characteristic feature when it is coming down to the compression of the vertebrae, okay, where there will be destruction of the pedicles. Okay, you see, this is the pedicular part, this is the pedicular part, okay, and you see here when we compare it to the right lateral surface of the vertebrae of the T10, you see here, this is the T10 vertebrae. Well, actually, it might be difficult for you to understand because we have already removed the concept of spine because of the time thing here, but they are included in the the practical slides, normal anatomy, how to recognize the uh, vertebrae and other things. Yes, so that's the reason I suggest you, actually, for understanding the concepts, learning knowledge wise, yes, please also read the practical slides in detail, but for examination purpose may not be necessary. The thing is that you can see here along the T10 vertebrae, okay, here along the T10 vertebrae, I can see that the pedicle has got completely loss of trabecular density. So this one is actually suggesting me the pedicular destruction, okay, where the pedicles have to be looked oval in shape, okay, on each side, but here I can only see that there is only one oval shape that is present on the left side, right? So loss of pedicular density and osteolytic lesion that is present down on the vertebrae is actually called as the pedicular sign, right? And the pedicular sign is actually indicative of osteolytic metastasis. Okay, pedicular sign is indicative of osteolytic metastatic bone lesion, right? And next we are going to look at multiple myeloma. I think this is the last disease we are going to look. Multiple myeloma, as like I already told you, it is also called as the solitary plasmacytoma. Okay, it is solitary in lesion. Okay, solitary plasmacytoma or disseminated form, which will actually cause as the punched out lesions or the skip lesions. The same thing you see here, they are actually called as the punched out lesions. Skip lesions also can be called as, they are called as punched out lesions, which is most of the times in examinations they will be asking out punched out lesions. Okay, punched out lesions are a characteristic feature of multiple myeloma. Remember that you cannot miss this diagnosis. Okay, multiple myeloma is a very classical and characteristic common disease. So multiple myeloma is the most common primary malignancy of the bones, right? So they have the punched out lesions, okay, or skipped lytic lesions are also seen, right? So you have already seen the picture, but we will try to understand the radiographic features in detail. They have diffuse and severe osteoporosis, first characteristic feature. Then they are expansile. Yes, they are looking big like a soap bubble. And septated lesions, there will be septations that are present in between, right? Which is actually the normal trabeculae that is actually being thickened there. And then frequently associated with soft tissue masses. So there is a soft tissue mass, there is a thickened uh, trabeculae, but complete other areas or loss of trabeculae will be there, which actually causes septate lesions. Then they are big, they are expansile, so that's the reason they have the soap bubble appearance. So soap bubble appearance along with septations and along with the soft tissue mass is actually called as a punched out lesion, right? Is this clear why we call them as punched out lesions? So punched out lesion is a characteristic feature of multiple myeloma. You can also call them as skip lesions, right? Okay, and then multiple small, sharply circumscribed lesions. So we call them as punched out lesions. Lytic lesions actually approximately of the same size are present and without accompanying the sclerotic reaction around them. So there is no sclerotic reaction around them. So that is how we are going to recognize these hypodensities. And then, classically, in detecting the lesions of multiple myeloma, conventional radiographs are more and more sensitive than a radionuclide board scan. So, you can say that the confirmatory diagnosis can be made down on simple radiograph itself. Okay, whenever you see a radiograph that is related down to the skull, you see here multiple myeloma, there are small lytic lesions all over the place. Okay, so it can be a characteristic feature of multiple myeloma. So salt and pepper sign is a characteristic feature of Paget's disease. Hair on end appearance or the cape sign hat appearance is also a characteristic features of Paget's disease. Punched out lesions, skip lesions, or soap bubbly appearance are a characteristic features of extensile, uh, expansile soap bubble appearance is a characteristic feature of multiple myeloma. Punched out lesions, skip lesions, and expansile soap bubble appearance is a characteristic features of multiple myeloma. A simple soap bubble appearance is a characteristic feature of giant cell tumor. Okay, so let me share a picture of a normal giant cell tumor uh, when compared it to the sub expansile soap bubble appearance. This is the classical picture you will always be looking at. Just a second. Okay, look at the image I have sent you. This is the classical image. Most of the times you will be looking in most of the textbooks. Yes, these images are used. Can you appreciate the presence of a soap bubble there? Looks like a soap bubble. Have you been looking on the pictures? Right? You see here, These are the classical pictures you actually find in most of the textbooks. Generally, you see here, Benedict, the answer to your question, one, how can we actually differentiate them? How can we actually differentiate if they are having the same names or if they are having different characteristics? Actually, the classification of the bone tumors, okay, the classification of the bone tumors is generally done based on their distribution, okay, their distribution in the just a second. See, the differentiation of the bone metastatic lesions or the neoplastic diseases of the bone or bone cancers is actually done depending upon their distribution in epiphysis, metaphysis, and diaphysis, and the surrounding soft tissue structures. Okay, so the classification of bone diseases is actually done by that way. So you have to remember that way. Okay. Well, if you have completed the classification of bone tumors in pathology section, you could have understood, yes, they are included down in the practical slides. Okay, what kind of tumors come in what kind of part. Okay, metastasis, if it is happening in the metaphysis, if it is happening in the diaphysis, if it is happening in the epiphysis. So the classification is actually done by that one, not exactly by the appearances. Okay, so to make it actually a lot of confusing, so that's the reason our examinations seem to be a little tougher. That's what I actually wanted to say. Yes, Benedict, you are correct. They have different characteristics, but appearances, when it is coming down to colloquial terms, when you are trying to describe it in a single sentence, yes, it may be confusing. All right. Yes, so Shubham, I think you have asked, Dravendra, you have actually asked me to show up the pictures. So now can you actually appreciate the difference between an expansile soap bubble appearance and a general soap bubble appearance of a giant cell tumor? Yes or no? Right? Okay, so punched out lesions, multiple myeloma characteristic feature. The last disease, okay, give me 10 more minutes. I will complete off this chapter. Okay, so we are going to learn about one of the most important bone infection. Okay, you should never ever forget or ignore this kind of a condition, which is actually called as osteomyelitis. Osteomyelitis refers to the focal destruction of the bone, which is actually happening by a hematogenously spreading infection and most commonly caused by the staphylococcal aureus. Okay, and it is a common disease that is happening in the children where the osteolytic bone lesions tend to occur at the metaphysis because of its rich blood supply. Okay, so remember, osteomyelitis is caused by staphylococcus aureus. It is occurring in the metaphysis, generally in children. Okay, it is an infection. Multiple myeloma is a malignant primary bone cancer, right? And then Paget's disease is a metabolic bone disorder. So, so all of them are entirely different clinically, but the appearances might be having the same features, right? Okay. So osteomyelitis, generally what they will have is a focal cortical destruction, periosteal new bone formation. Okay, I will just show the image. You can actually understand, and there will be surrounding soft tissue swelling and focal osteoporosis. Okay, so there is a thing that is actually called as the periosteal reaction. Before I told you what is a periosteal reaction, right? Okay, now see here, it is actually a particularly characteristic feature which is called as the periosteal reaction. Okay, I think you have to always learn about this one for sure. Let me show periosteal reaction. Okay, look at this image. Look at this image, what I have just sent you, right? The image actually shows that there is, just let me open up. Just, okay, here in this picture, when you actually see here, you see the periosteum actually became prominent. Generally, periosteum should not be seen, but the periosteum actually became prominent, right? The other thing we can also find out here that the cortex has been thinned. That is also fine. So such kind of appearance is actually called as a periosteal reaction. And when you actually look closer, the periosteum is actually going to be get peeled off. It actually looks like as if it is going to be peeled off from the surface of the bone. So such kind of appearance is actually called as a laminated periosteal reaction, which is a characteristic feature of most of the times a neoplastic condition. And you see here, this is an osteosarcoma patient, and you see here, when you look close enough, there is a thin layer or a density that is seen as a white density here, right? So this is actually the periosteal reaction. So, and you see here, when you look close enough, you see here, this one is the laminated periosteum, and you can see here there is a more increased density of the periosteum. So this one is actually called as a Codman's triangle. Yes, it is actually called as a Codman's triangle. Okay, Codman's triangle is an area of the periosteal reaction which is forming a triangular shape like density with the surface of the periosteum. Okay, right? Very simple. It is not difficult to understand. Is the concept clear? It can be a characteristic feature of so many conditions. Okay, most important characteristic disease is the osteomyelitis. Can you see it? Right? Can you see it? Okay, you see here where the arrow has been passed, here that one is actually showing up, forming up as a triangle here where the periosteum has been peeled off. So that's the reason it is called as a periosteal reaction. That's true. And again, you are also going to look at the lamination. So this one is a characteristic feature of periosteal reaction, and this is a characteristic feature of osteomyelitis. Remember, do not ever forget Codman's triangle. Codman's triangle is a characteristic feature of osteomyelitis. Well, actually, Codman's triangle is the triangle that is actually formed by the, you see, is the triangle formed by the surface of the bone cortex, okay, surface of the cortex, and to the periosteum that has been lifted off, which forms an imaginary triangle. So that is actually called as the Codman's triangle. Aman, look at the picture I have sent you. So that is how a Codman's triangle is, right? Can you see it now? Did you understand, or you want me to still explain in more detail? Right, so remember, Codman's triangle is a characteristic feature of uh, you know osteomyelitis. Okay, then you guys want to take a rest, or me to complete off because there is something around like 8 slides that are left. Complete? Continue? Okay. All right. You see here, remember periosteal reaction. Periosteal reaction is a formation of a, you know, you can say that it is actually removal of the periosteum from its bone surface. Okay, so periosteal reaction where the periosteum will be lifted off, so it is called as a periosteal reaction. And when the periosteal reaction is present and it is also showing along with a lytic lesion near it, okay, where there is a focal osteoporosis and along with the soft tissue swelling, that one is actually forming a triangle which is called as the Codman's triangle. So periosteal reaction can be a characteristic feature of so many diseases, but Codman's triangle is a characteristic feature of especially osteomyelitis. Okay, right. And you can actually say here that the Codman's triangle will generally not be formed on a any kind of a bone infection because it takes time to develop, and it takes around 10 days, which is actually called as an acute osteomyelitis is the first finding. Okay, right. And a Codman's triangle generally seen in situations of the first 10 days where you will be seeing only periosteal reaction, right? So Codman's triangle is generally a characteristic feature of chronic osteomyelitis. Periosteal reaction is a characteristic feature of acute osteomyelitis. All right. So it is entirely different. So you have to differentiate it between the acute osteomyelitis and chronic osteomyelitis. So both of them are different. If it is happening within 10 days, it is actually called as an acute osteomyelitis. Okay. And MRI and nuclear medicine scans are actually very, very useful for earlier diagnosis. So do not confuse yourself here. Conventional radiograph are not sensitive for diagnosing acute osteomyelitis. Chronic osteomyelitis, yes, they are sensitive. Conventional radiographs are finally sensitive. But acute osteomyelitis, the confirmatory gold standard diagnosis for acute osteomyelitis is an MRI scan or nuclear medicine scan. Remember it that way. Okay. Now, you see here, there is an osteodestructive lytic lesion that is present down. Okay, what is the organ that is here? What are we looking at? We are looking at the tarsal bone, right? See, in the tarsal, okay, in the distal end of the second metatarsal, we can actually see that there is a heterogeneous osteolytic bone destructive lesion. Okay, osteolytic or bone destructive lesion, both of them meant the same. There is an osteolytic bone destructive lesion that is present down on the distal end of the second metatarsal, right? And you can also see that there is a periosteal reaction, which is actually called as the laminated or the stripping appearance. Okay, stripping of the periosteum, we call it as, and which is actually called as the osteomyelitis. You can see some areas are blacker and some areas are particularly whiter. So this one is actually the new bone formation. So that's the reason we call this kind of a condition as a bone within a bone appearance. I think you have heard this term in pathology, right? Bone within a bone appearance. Bone in a bone appearance or bone within a bone appearance is a characteristic feature of osteomyelitis. Yes, it might be happening because of streptococci. Yes, TB also shows bone in a bone appearance, but particularly the bone that has been formed down in TB is actually called as involucrum. Okay, and the destruction that is actually happening is actually called as sequestration. Right? So you just need to know these terms. Okay, you need not remember because all of the radiographic appearances looks the same, right? And The last one we are going to look at is the pathological fractures, right? Yesterday also we saw something that is related down to the pathological fractures as well, and they generally are called as the insufficiency fractures. Remember the term? Insufficiency fractures are called as pathological fractures where there is no trauma that is associated with it. Okay, so insufficiency fractures are a common characteristic feature of metabolic bone disease densities, metabolic bone diseases, right? Particularly related down to osteoporosis, or you can say insufficiency fractures are seen in osteoporosis. Simple like that. The question will be coming down like insufficiency fractures are seen in osteoporosis. They are a pathological fracture. There will be no trauma that is associated with them. So what actually happens? They can have a diffuse radiographic features. They can have very broad radiographic features. They can have increase in the bone density. Increase in the bone density actually suggests that there has been activated bone healing. Decrease in the bone density, you can actually say that there is a necrotic reaction or increased osteoclastic activity, right? So depending upon the progression of the disease, they can be actually present down as increase or decreased bone density, and they weaken the normal architecture, right? And then they can be local or they can be diffuse, they can be broad, they can be wide. Okay, and generally they are seen in ribs, spine, and proximal appendicular skeleton. Proximal appendicular skeleton in the sense you are talking about the humerus, or the completely upper limb. Okay, or you are generally talking about the head of the femur. It is also proximally present, right? Even though the limb is present distally, the part of the femur is actually the part of the leg, upper leg, right? So we call it as the proximal region. So all the proximal appendicular skeletons, for example like humerus, for example like the femur, or for example to say like the upper end of the tibia, okay, or up proximal ends of the the vertebrae, all of them are actually called as the proximal appendicular skeleton. So they will be are seen in ribs, spine, and proximal appendicular skeleton. Pathological fractures, and they are characterized by delayed healing. Okay, so that's the reason there will be different densities that are present here. Okay, either they will be present down as the new bone formations, or either they will be formed down as completely osteodestructed lesions. So multiple fractures may be present, and the characteristic feature is a wedge compression fracture. Okay, and you see here, this is a pathological fracture that is actually happening along what bone? Can you take a guess? What is this bone that is being shown here? Okay, which part of the humerus? It is the distal end of the humerus. Around the, we are looking around the cubital joint region here. Okay, how can I recognize it? Yes, it is the shaft, distal shaft, particularly saying distal shaft. Right. True. So I can see there is a osteodestructive hypolytic lesion that is present along the distal diaphysis. Okay. Right. And there is a pathological fracture line that is present. How can I say this is a pathological fracture line? Pathological fracture lines are smooth, but a traumatic fracture lines are sharp. Do you remember the difference? So that's how I can say that this is a pathological fracture. So it can be happening because of a metastatic renal cell carcinoma. All right. So I think that is what we are going to talk about the pathological fracture. Last image you can remember about is the wedge compression fractures, which is also related down to the pathological fractures as well. Okay, wedge compression fractures are very characteristic classical features of bone tuberculosis. Okay, which is happening because of Pott's disease, right? Right, you see here, Pott's disease. You can see that the vertebrae has become, in that image actually the vertebrae has become completely triangulated. right? It became like a wedge. It became compressed from the both sides. Okay, so that's the reason we call it as the wedge compression fracture. And wedge compression fracture is a characteristic feature of bone tuberculosis, particularly spending going down to the spine. All right. Yes, can everybody see it? Okay, just try to look at the other image I have sent you. Okay, it is actually the wedge compression fractures. Okay, and the destruction, it is actually happening because it is particularly seen in the spine. All right, so they are also characteristic feature of pathological fractures, right? So I think we have completed the metabolic bone disorders as well. So we still have left like one chapter,